Hello, everybody. I'm Jeanne Poole. I am the editor-in-chief of Heart Rhythm O2 Journal. And welcome to the HRO2 series highlighting the contributions of great electrophysiologists from different countries, especially their early foundational work. I have with me today Dr. Uma Srivatsa. She is our HRO2 section editor for our Global Voices section, and our guest, Dr. Bernard Belhassen from Israel. Dr. Belhassen, it is such a privilege to have you with us today. I don't think much introduction is needed, but for our younger colleagues who may not be aware of the legacy that you have given to EP, I just want to give a brief introduction. So, Dr. Belhassen is a professor emeritus at Hadassah Hebrew University in Jerusalem. He graduated from the University of Paris and then trained in cardiology and electrophysiology in the 1970s at the Ferdinand Wiesel Hospital in Paris under the mentorship of Gilbert Mott. He then returned to his home in Israel and established the first electrophysiology lab in Tel Aviv. Within a short period of time, colleagues Michael Elder and Boris Strasberg established EP labs in 2 additional Israeli hospitals, one of which Dr. Belhassen notes in his paper was already active under the guidance of Dr. Samuel Sklarowski, an Argentine-born ECG specialist. Dr. Belhassen has authored nearly 250 manuscripts, many of which were groundbreaking discoveries. As Dr. Belhassen notes at the beginning of his manuscript, and I quote, "Working with other greats, Philippe Kumel, Hein Wellens, and many of the foundational concepts of cardiac electrophysiology, both normal and abnormal, were discovered, resulting in the birth of clinical cardiac electrophysiology, a new subspecialty in cardiology." Dr. Belhassen, you have given our readers an in-depth and informative overview of which we can only tap into a few of the remarkable accomplishments that have emerged from Israel. And thus, I strongly encourage our listeners to read this wonderful synopsis. But let's start, and I will turn this over to my colleague, Dr. Srivatsa, to lead us off for the first part of our discussion. Uma.
Thank you, Jeanne. That was a wonderful introduction of Dr. Belhassen. Dr. Belhassen, it's an honor to meet the person who's described fascicular VT. I recall reading about it as a fellow in UCSD where I trained, and we saw the cases, we got excited. Can you share the story of how you initially identified this VT as an unique entity?
Okay, I will do it. But before that, I would like only to say that I'm born in Tunisia. And when I was 10 years old, my parents were obliged to leave a magnific country, which was Tunisia, to France. So I lived 20 years in Paris before moving in Israel in 1978. So this is the story. Now, about the Belhassen VT, it's fantastic because about 1 year after I got in Israel, I got a phone call from Professor Kaoli, who was director of the cardiology department in Rehovot, 35 kilometers south from Tel Aviv. Told me that he has a magnific case of mild tachycardia. He is not specialist in electrophysiology, but he knows what was mild. He sent me the traces, and I saw a tachycardia, regular, RBBP left axis deviation with AV dissociation. I told him it cannot be mild because at this time we already knew that mild also almost always has a left branch block pattern. So I told him, it's not mild, forget it, it's ventricular tachycardia. But he said, get back, the verapamil stopped it. I said, okay, so this is ventricular tachycardia terminated by verapamil. And he told me, but I looked at the literature, there is no cases of ventricular tachycardia terminated by verapamil. Wellens published a few cases a few years ago, and he didn't find that the verapamil was effective. And I said to him, okay, so this should be the first case of ventricular tachycardia terminated by verapamil. So I wrote the paper because it was a fantastic case. So inducible VT with lateral pacing, ventricular pacing, terminated with lateral pacing and ventricular pacing. Verapamil IV slowed brings the tachycardia with just before terminating it. There were major repolarization changes in the posterior interlateral leads due to memory phenomenon. At this time, I knew all that. And the fantastic this guy that has done a lot of VTs, and a lot of time he was giving the verapamil, because in each file it was recording that this is supraventricular tachycardia with aberration terminated by verapamil. So we had the experience with this guy that always tachycardia were terminated and slowed before termination by verapamil. So I sent a paper to Dr. Dennis Krickler, who was the editor in British Heart Journal, who were very happy to accept it, and this became the first case of. Now, interestingly, about a few months during all the process of publication, Dr. Zipes published in the AGC in 79. It was about 2 years before my publication in British Heart, 3 cases that he said, I'm talking here about 3 cases of normal heart, ventricular tachycardia, MBBS left axis deviation with a mechanism of re-entry or triggered activity, but he didn't give a verapamil. So it was a little bit different, because I said that verapamil may be effective. So I collected 2 other cases, I made other publication, and in this publication I proved that all cases of idiopathic ventricular tachycardia with MBBS left axis deviation pattern are sensitive to verapamil, they are slowed and terminated. So I think this was the entity was described by me, but few cases of MBBS left axis were described before. What is fantastic in this story, after my publication, there were a huge number, especially from Southwest Asia. Very interesting. And for reasons that I don't know the reason till now, I'm sure that there are many cases of Belhassen VT or fascicular VT, as you would call, which are predominant in Southern Asia, and we don't know why. What I forgot to tell you is that about 3 years before this publication, when I was training in Paris, I remember a 23-year-old student who was born in Cambodia, who had the same tachycardia, but he received only adenosine triphosphate, which didn't affect tachycardia. So I already saw such a case, but without giving verapamil. So what is fantastic in all this story is how now it's fantastic to see that you can, abolish it and cure patients, and sometimes complicate them. And this horrible complication of ablating tachycardia was published by my great colleague and friends, and Sami Viskin, in Heart Rhythm. It was, I think, 2 years ago. It was an horrible case. So, in Israel, in Ichilov Hospital, was described first case of Belhassen VT, and was also reporting the first case of horrible complication due to ablation of this fascicular VT.
So, Dr. Belhassen, so at that time in the 70s or early 80s, quinidine, adrenaline were used for VT therapies. So what made you think of verapamil? What was the thought process behind that?
No, because verapamil was given to this patient many times before I knew him. He had tachycardia since he was 80 years old. I knew him when he was 28 years old. So there was a story of recurrent tachycardia considered to be supraventricular tachycardia because they were responsive to verapamil. Because people are not looking to ECG, and they did not look that this patient has AV dissociation. This is the story.
Interesting.
It was really fortuitous then that patients simply were being treated as if they had a SVT and being given verapamil, and it happened to work.
This is the typical cases.
Yeah. So moving on, Dr. Belhassen, you also described, you were probably one of the first to describe idiopathic ventricular fibrillation in a patient where you were able to target it with quinidine therapy and did not require ICD long term. I mean, the current guidelines is if a patient has syncope, idiopathic ventricular fibrillation, we recommend ICD implantation. But what are your thoughts of either antiarrhythmic therapy or even ablation now that we have a lot of advances rather than ICD in a young patient like that?
Thank you very much for the question. As a preceding case, the experience I acquired in the field of idiopathic VF and its treatment with quinidine became very, very incidentally. On February 23 of 79, the same day our first son is born. Just before leaving the emergency room, after examining a 75-year-old patient with an acute inferior MI, I found an ECG on the floor that I rushed to pick up. Out of curiosity, I took a look and was surprised to note very short coupled ventricular extrasystole in the setting of an otherwise strictly normal ECG. I was told that the ECG belonged to a 29-year-old man admitted with recurrent syncope who was in a way to be discharged home after a consulting neurologist referred him for ambulatory EEG for suspected epilepsy. After discussion with the patient, his wife, I had the feeling that we were not dealing with epilepsy, but with something else, because the recovery after the epilepsy was already fantastically fast. So I'm not a great neurologist, but I'm a good doctor. I know that after epilepsy, you are not recovering so fast. So I called the secretary in the ward. I told him, I don't want to hospitalize the 70-year patient with acute MI. I prefer to take this 20-day. Dr. Belhassen, impossible. Impossible. This is the acute MI. This is syncope. I said, no, I want this guy. So I took this guy in the department. A few hours later, I was called. I was in my room. Dr. Belhassen, come immediately. I come, room number 1, and he say, the missing patient, the young patient with a recurrent storm of ventricular fibrillation. I personally give 10 shots to this guy. Twice, I didn't give shock. I tried to see what will happen without giving shock. After, let's see, 15 seconds. Twice, the ventricular fibrillation terminated spontaneously. So I have now the explanation, the reason of a syncope, and the diagnosis of short coupled ventricular fibrillation in a patient with no obvious heart disease. We only had echocardiogram, which was normal, and coronary angiogram, which was normal. Okay, and the ECG was normal, so I think no myocarditis and no other disease. Because the patient was very, very active, almost no medication was helping him. No procainamide, no amiodarone IV, no ventricular pacing, no lidocaine, no potassium, no what you want. I remember my previous boss in Paris loved quinidine. I said, why not? Why not? Because I have no other resort. The patient will die. I gave to a patient quinidine, and I noted fantastic improvement. So, in the same patient, after that, I repeated the electrophysiologic study on no medication. It was inducible very easily to ventricular stimulus. I repeated the program stimulation. Add the quinidine, 1,500 milligrams quinidine, the patient a non-inducible. Don't forget, at this time, we had only the possibility to deliver with a Medtronic 5325 battery stimulator, only 2 extra stimuli, only 2, not 3. But because I had the induction very easily with double, and not with double after giving the drugs, and doing a lot of repetition. It's like that I learned what is the value of repetition. Without repetition, there is no value to electrophysiologic study, no value. But nobody will write it in the paper that we did a lot of repetition before inducible behavior. So a patient was not inducible after I gave to him quinidine, and this is the story of this patient. So this patient has been treated 40 years and a half with quinidine, 1,000 milligrams, didn't get a defibrillator because it was in 79. And personally, I thought that nothing best than, quinidine, because I repeated in this patient EP studies, every 5 years, every 10 years, I repeat it, to be sure. Until this guy needs heart transplantation because severe got a donor problem, and he died because of a complication of but he lived almost 41 years on quinidine without defibrillator. I can tell you that if I had implanted the first defibrillator of Berezovsky in 81, the patient should have died in 86 because infection caused by defibrillator and explantation, replacement device. I'm sure the patient I would have killed him. Now, what is interesting that in 90 was published a case of a patient quite similar to that, who received quinidine for idiopathic fibrillation with OTP, of course, in 48, who died in 91 because cancer. The case was published, the same story. It means you have arrhythmic storms, a lot of syncopes, arrhythmic storm, quinidine, blind, of course, without an EP, and the patient away. I'm convinced. I can tell you that because I have, some experience of it. That I would not say empiric, but even empiric, but it's impossible today to give empiric treatment quality. It's simple. It's not illegal. It's impossible to. But if you have a patient who does not want ICD, who had complication of ICD, okay, who had storms or not storms, infrequent episode of VF, in one, you induce VF at baseline, and you repeat the EPS on quinidine, and you are enabled using a lot of extra-stimulation, the robotic repetition. You can avoid induction of VF. I'm sure this patient is responsible treatment. He doesn't need ICD. The problem is medical legal. I understand. In the States, it will be impossible such as that. Sometimes you may have a patient who say, I don't want complication of ICD, For example, if the mean age of idiopathic VS is around 40 years, this patient should die when it will be, 90 years. 50 years of defibrillator. 50 years of defibrillator. Nobody wants to think to that. I can think to 50 years of quinidine therapy. I have big difficulties in thinking of 50 years of ICD therapy. This is my policy. Now, this policy is not only valuable for the idiopathic VF patient, but also for the Brugada patient. But now, in the Brugada, we have the epicardial ablation. So people are saying, okay, we have a severe patient, we are doing epicardial ablation. Note that no doctor today, okay, has recommended removing ICD or not implanting ICD in patient undergoing epicardial ablation. So the patient will have ICD, also, of course, ablation, and it's terrible, terrible. Some people are getting also quinidine and ICD and so on for years, and nobody will have the courage to say this is superfluous. This patient doesn't need that. All but because of the guidelines, Now, I'm telling you now the truth. It's exceptional that I look to guidelines. I'm very happy to see that nobody asked my corporation to write the guidelines. I will not say against guidelines, but I'm not a fan, okay, of guidelines. But this is we say in French, mal nécessaire, or something which is wrong, but it is necessary.
That's very interesting. Yeah. Dr. Belhassen, that tells students, younger physicians, how important the significance of observation and out-of-the-box thinking or evaluation of new phenomena, treatments, etc. But I think
just make a comment to Uma, because I think that this is such an important point about the use of implantable defibrillators. I think that we're in an era now where we are starting to broaden our perspective on, whether every patient with certain entities actually need a ICD or not. But you're right. When you've got guidelines and you've got somebody who had a cardiac arrest, it's very, very hard to not implant an ICD. When you have a young person, though, the fact that they're going to face, lifelong generator replacements, leads that won't last their lifetime, I think it's quite reasonable to take a look at that and have that kind of conversation with the patient about the risks and benefits of the different approaches. I don't know, Uma, what do you think?
Absolutely.
You can use, for example, the drug option as a bridge. As a bridge. You say to a patient, okay, I do understand that maybe when you will be used all that so on, maybe you don't want to take medications. Okay, so we have possibility at this moment, to make the ICD. You can't do it. It's very difficult to make. I can only tell you that it is quite difficult today to fight the problem with the ICD. It's also impossible. It was possible at the time the ICD was not available. It became very difficult. Now, an important point now in all the problem with quinidine, ablation, and so on, I can tell you now, because we are working. I started a fantastic work on comparison of quinidine versus ablation in patients with short-coupled idiopathic VF. Okay? So I started this multi-center study. I designed it, and I'm very happy to give you now the very, very, very preliminary. I have a patient, a paper in consideration in JACC, and okay, but for Harvard, because I love you, I will give you some interesting results. We had this multi-center study included 287 patients with idiopathic VF and short-coupled idiopathic VF demonstrated, okay? And I can give you the results we have. Of course, it's a retrospective analysis of result, okay? The stats, not prospective. I can tell you this big surprise for you, that therapy success for when you have a patient with short-coupled VF, the first group would have ablation, the second group will receive quinidine. Now, these are the results. Therapy success was achieved in the ablation group in 62% of patients, one ablation, first ablation, but 71% of patients will be treated more effective by quinidine. The P is not significant, but only to tell you how quinidine as a first-line therapy is even a little bit, maybe 10% much more effective than ablation. So if today, now, in your department, you have a patient with very weak stones, okay, you can try to manage, emergency cases, ablation, and so on. But if you have quinidine, I think will be the best for patient, because quinidine will abolish the arrhythmia in about 90% of the cases, research time. Okay? So, viva quinidine, we say in Spanish. Viva quinidine.
Well, let's talk about another entity that you've published really vastly on, and quinidine comes into play here also, and that's the Brugada syndrome. And in your paper, you nicely summarize, of course, the really groundbreaking work of Sami Viskan, our new editor-in-chief for Heart Rhythm Journal, for all of his pioneering work. But I was particularly interested in your findings from the Sabras. I'm not sure if I'm saying that right. The Sabras survey.
Is fine.
Yeah, and if you could talk about that a little bit, and maybe even especially about some of these racial and ethnic differences. I wanted to share with you that I had an early interest in this topic because when I was training back in the 1980s, we had this large population of immigrants from Southeast Asia that came into Seattle. And of course, we were working with the Medic One system, and we had a lot of people who survived out of hospital cardiac arrest. We began to really note that these people tended to die in their sleep or have their cardiac arrest in their sleep. And Dr. Catherine Otto, who is, of course, best known for her groundbreaking work on the echocardiographic assessment of aortic valve stenosis, she published a little-known paper in 1994 in the Annals of Internal Medicine, describing sudden cardiac death in Southeast Asians. So I've sort of always been interested in, following these different groups of people that have been studied to try to tell this whole story about Brugada syndrome. So I was just curious if you could speak to the racial ethnic differences a bit from what you identified in your survey.
Okay. So it was about 7 years ago. I had an idea. I said something like that. Pedro Brugada had in 2015 published a paper published in JACA. He had only 25 patients with ventricular fibrillation related to Brugada. Pedro. Joseph, his brother, also the same number. I, in Tel Aviv, had only 11. All my experience with cardiac arrest documented in Brugada patient is based on 11 patients only. So I say, impossible to advance without trying to collect all this data. Within 24 hours, I sent about 30 emails to all my friends, because I'm in Israel, so I'm not a big competition with in Europe. A lot of competition in the States, in Europe, between Italy, Spain, and France. Okay, but Israel is not a little bit outside. And because people love me a lot, I think they like me a lot. So I convinced them to send me all the data they have on patients with cardiac arrest or in patients with Brugada who had implanted LCD in which the an arrhythmic event was documented. Of course, I also contacted people from Asia, and you do not believe, within a few days, I gathered 678 patients. 678 patients who had either spontaneous VTVF or arrhythmic events in patients with Brugada who had prophylactic implantation of ICD. So you understand that we made 7 papers on that. I think all papers are fantastic because now I would like to answer Dr. Jeanne. Jeanne, you say that in French, we say Jeanne. So I don't know why Jeanne is I will call you Jeanne.
That's perfectly fine.
Yeah, it's okay. It's fine. Okay. Now, I would answer your question about the support of no.
The
ethnic-
racial,
ethnic
look,
groups.
the differences in the racial and ethnic
No.
representations of
Okay.
Bernard Belhassen.
First of all, Severus, we have confirmed some, for example, male prevalence in Severus was confirmed. We had 90% of males and 10% of female. We have exactly the same with our 11 patients. We have 10 males and 1 female. Okay. So nothing new in that. But what it is very interesting, what we have 2 age group, the pediatric group and the group age more than 50 years, in which the male prevalence was not true. Interesting, okay? So, the reason is what happened there and why it happened means in the pediatric groups, less than 16 years, and the group age 49 years, we have much more females. Now we have tried to explain that, and I didn't give explanation. I only take from some basic study. We say that when the estradiol level is lower, you have much more arrhythmic events. In contrary, in a woman between age 16 and until 49, okay? When the estradiol level is highest, less arrhythmic event. So this is, for example, as I'm talking about the story of Jeanne. Now, Jeanne, I will talk to you. I will give you some interesting finding about genetics, about ethnic difference. First, the age onset was not different between white and Asian, okay? But 40, 41 years old, no difference. But a higher proportion of whites were observed in pediatrics and elderly population. Almost no Asian patient there. Interesting. Why? I don't know. 3. Asians were predominantly men, almost 100%, exceptional to see an Asian people with family. Why? No explanation, okay? And another difference is that the Asians were tended to have much more spontaneous Brugada 1 pattern than white. Why? No reason. Now, Jeanne, what do you remember of your case, of your special case?
What I recall is that they were from Cambodia and Laos predominantly. And really, I think the primary observation that we noted back then was the fact that they had their arrests while sleeping. I don't recall if we were, for instance, describing the electrocardiograms in any specific way back then.
Did you remember, for example, female patients from Asia with Brugada and the cardiac event?
I mean, that's a great question. I really don't recall. Somehow I feel like I saw more male patients, but that could be wrong. It was a couple decades ago.
There are some really big difference between ethnics, in the Asian. Personally, I have no explanation. It's important to know about that, for example, okay? No females with arrhythmic events in Asia. Why?
So, Dr. Belhassen, you also have described in that survey, first of all, it's a survey, right? So there could be the selection age
Right.
selections could be that. And second, is, there's less SCN5A mutations in Asian population. Could there be some sex-specific gene abnormalities? Is there any genome analysis that's being done at this time? I think we're kind of coming close to the end of our interview here. So if you can give us a brief information about any of that.
I can only tell you, because I'm not specialist in genetics, I can only tell you about one findings which is quite fantastic. Is that in whites, there is a very significant high rate of SCN5A mutations. In whites, it's 40%, and only 13% in Asia. Why? No. So there are some big difference between two groups. I'm sure that, and when you look to the specific studies in Japanese population, for example, you will have a confirmation of what I found here. Okay. Another interesting is in female, for example, female, which are rare. You know how many female handicappers? 59. Only 59. I have seen in my life 2 cases. One case publication, one recent case. Only 2. But all Sabrus is only 59. But what we know that in females, many female patients have the mutation, are carriers of mutation, much more than males.
Yeah.
Why?
I don't know. There's a lot to learn yet. So it's an exciting area. Yes. The discovery never stops. Well, I do think that we have to wrap up our discussion. It's been absolutely wonderful, very insightful, and just a lot of fun. And I just want to thank you, Dr. Belhassen, for this discussion this morning.
Thank you.
And sharing the Israeli legacy with us, including your own amazing contributions. I'd like to thank my cohort here, Dr. Uma Srivatsa, for joining us today, and especially all of our listeners. And please take the time to read the paper. It's amazing. You'll learn a lot. And for those of you who are young in electrophysiology, it's so important for you to know the contributions of EP doctors around the world, and really the foundational concepts and how they were discovered and identified. So with that,
I'm still very, very young, John. Don't forget it. I'm only 47, 4, and no more than that. Okay.
All right. Well, thank you everybody again for joining us all today. Have a great rest of your day or evening or morning, whatever time it is that you're watching this YouTube production.
Thank you.
Thank you, Lord. Bye-bye.